teacher is among us and who has consented to be a faculty moderator for today's case capsule, and Dr. Partha Pathim Chakrabarti, and he is here. And thank you, sir, and thank you. We are grateful that you accepted our invitation to be a moderator, and we would be discussing a difficult case of rickets today during this case presentation, which will be presented by Dr. Anushtup Mukherjee. And we also, as usual, we are having a panelist who are volunteers and who will be facing your questions, sir. And Dr. Shilika Lalwani is the endocrine student, resident DNB student from Army Hospital R&R Delhi. We have Dr. Somin Dhaneria from a DM student from Indore. We have Dr. Sania from Nizam Institute and Dr. Nupur from Delhi Max Hospital. So they would be facing your questions, sir. And before I hand over the dais to you, we have among us the respected Dr. Kaushik Pandit, the President-elect of Endocrine Society of India. And I would just request Dr. Kaushik, sir, to please address the students and give some few words of motivation to them. And after that, sir, we'll hand over the dais to you.
Thank you, Sandeep. It's indeed a privilege, and it is my privilege to join this Endocrine Society of India's very own initiated program of ESI Case Capsule. Endocrine Society of India is the largest body of endocrinologists spread all over the country. It actually serves the purposes of all the members of the Endocrine Society of India, but it has not forgotten its responsibility to look forward and help our younger brothers and sisters who are going to be inducted into the society within a few years from now. And with this in mind, the ESI Case Capsule is an opportunity for everybody, including the very elderly endocrinologists, very senior endocrinologists, and the endocrinologists who would be inducted into the fold, who are still doing their DNB or DN training, to discuss very important cases, which is very akin to what they face in the exams. This way, they sharpen their skills and be better endocrinologists with time. And this is also a very important opportunity for the senior endocrinologists, not only to learn, but also to share their nuggets of knowledge and wisdom with all the people online, especially the ones who are available here. So with this, I would welcome everybody who has joined to enjoy this session of ESI Case Capsule by Endocrine Society of India. Thank you.
Thank you, sir, and thank you for those words of motivation. And in fact, I would agree that we, in the lieu of training for the students, I must agree that we, people, even the senior endocrinologists learn from this case capsule, and we go educated from all the sessions. And so thank you once again. And sir, we hand over the dais to you. And I would request Dr. Anushtup Mukherjee to share his screen.
Thank you. A very good evening to all of you. At the outset, I must thank ESI and Dr. Pandit in particular for this kind invitation. It has always been a pleasure to be a part of any program of our own ESI. So with these words, we have an interesting case of rickets. So for that, we have Dr. Anushtup Mukherjee, a second-year postdoctoral trainee of Medical College, Kolkata, will present the case. So may I request Anushtup to go through your presentation? Anushtup, you are muted. Please unmute yourself.
Yeah. Okay. Sir, just sharing the screen. Just a second.
Meanwhile, sir, I also apprise we have a quiz towards the end of this session, and the ESI has taken a very good, the initiative where we, give cash prizes to top 3 winners. It is 10,000 rupees, 7,500, and then for 5,000 to the third runner-up. So it is again.
So that will be based on rickets only or on endocrinology itself?
No, sir. See, we try to restrict the quiz to the topic of that day, and a little variation here and there, but generally it is restricted to that topic only. And we conduct it on Mentimeter, sir. So, in fact,
are you having any difficulties, Anushtup?
Sir, I'm just having a bit problem, sir. Just pardon me. Hello, sir. আসছে না স্যার, উইন্ডো কি আসছে না স্যার, এক মিনিট স্যার, কেন আসছে না স্যার, বুঝতে পারছি না অপশনটা। না স্যার, আসছে না। এক মিনিট স্যার। Yes.
I think Onustub has having some problem in sharing the screen. So can I share the screen for Onustub?
Yes, sir. I think we can go ahead and we can do that ways.
Are you done, Onustub?
Sir, we are able to see the presentation now.
So this is my screen.
Yes.
Onustub is facing some problems in sharing the screen. Just a second. তোকেই দেখা যাচ্ছে।
Sir, click on slideshow button.
Is it your screen? This one?
This is Onustub's screen.
Okay,
So
fine.
Onustub
So
has
now go
to.
to the slide mode. Try to move your slides. No, it's not moving.
Yes, we can see your screen now. Dr. Anushtub's screen is visible to us. Dr. Anushtub, we can have, if you can put it on a slideshow.
You unmute your. Go to the
Yes.
slide.
In the presentation, right, sir?
Right.
Yes. Sir, is it now?
No, it's not moving.
Sir, is it
No, it's
is it
not
now
moving.
moving?
No,
Sir, now is it?
no. Go to the slide number 2.
Sir, is it
On
doing
the
now?
left
No.
side. Now it's moving. Now it's moving.
It's moving now.
Yeah.
Okay.
So, okay, go through your presentation, we'll see.
Sir, is it
Right,
moving
it's
now?
moving. Yeah, it's moving.
It's moving. Okay. Okay.
Yeah, over to you, Anustup.
Yeah. So, good evening, everybody. So, I'm a bit sorry for the technical glitch. So, am I audible? Am I
Yes.
audible?
Yes,
Yes.
fine. Good to
Yes,
go.
you are.
Yeah. Okay. So, it's a case of difficult rickets. So, we start with the history part. So, this is a 17-year-old, 17-year, 3 months old male. So, his residence is Midnapur district in West Bengal. So, his first presentation was in December 2023 in our institution when he was 15 years, 10 months age. So, his presenting complaints were progressive bowing of both upper and lower limbs since the age of 4 years and inability to stand and walk for the last 4 years. So this patient was born out of consanguineous union, fourth degree. He was a third child, termed normal vaginal delivery. His birth weight was 3.5 kg. Vertex presentation. There is no history suggestive of any delayed cry. There is no history suggestive of tetany, seizure, or fracture during postnatal period. And exclusive breastfeeding was done till 3 years of age. And there is history suggestive of delayed motor milestones. Now, his parents sought first medical consultation for delayed standing at 1.5 years of age. And he received oral calcium and vitamin D. The doses were not specified. He started standing and walking around 2 years of age. But he noticed gradually progressive swelling of wrists, ankles, knees, along with bowing of both upper and lower limbs since the age of 4 to 5 years. The history suggestive of bone pain was present. There was no past history suggestive of any proximal myopathy. And there is history suggestive of delayed eruption of permanent teeth. Now, regarding the treatment that he received earlier, there is a history that he received injection cholecalciferol, single dose during the diagnosis, but the dose has not been specified. He has also received sought medical attention at various physicians from time to time, received different calcium and vitamin D preparations, but the doses are unknown. And also there is history suggestive of poor compliance to medications. And the parents also gives history that they have stopped the medications for 5 years since the age of 7 to 8 years. Now, there has been severe increase in bone pain and deformity since that age till presentation in our institution at 15 years of age. And patient is unfortunately bedbound for the last 3 years due to the bone pain and deformity. Now, the diet history, the patient takes around 600 kilocalorie of diet. Milk intake almost nil. Regarding other relevant history, there was no history suggestive of any seizure. There is no similar illness in the family. There was no history suggestive of polyuria, polydipsia, renal stone, or any fracture, and no history suggestive of any malabsorption or gluten enteropathy. Although there are some positive history regarding some history episodes of occasional tetany while crying, there is history suggestive of poor exposure to sunlight because patient being having deformities and also got bed bound for the last few years. And there is also a recent onset painless progressive dimness of vision in left eye.
Anustup, you stop here. Anustup, you stop here. Great. So can we have some discussions? So may I request one of the panelists to discuss over the importance of history of seizure or tetany in such cases?
Uh, uh, Good evening, sir. This is Dr. Somin. So, in case of history of tetany or seizures, that would point towards calcipenic rickets. The etiology towards hypocalcemic seizures can be there, or there can be tetany in that case. Family history would be more suggestive of the phosphopenic rickets, and the familial causes, genetic causes.
Sorry. So don't you expect a positive family history in so-called calciopenic rickets?
Yes,
So you
we
get
do.
a positive family
Yeah.
only in phosphopenic rickets.
No, we do, sir. Even in the calcipenic rickets, we do, because of these genetic causes. We do expect a positive family history here also, and history of malabsorption or gluten enteropathy here is said because we need to rule out any transcellular shift or any decreased intake, nutritional causes, or any malabsorption, severe protein allergy, malnutrition, refeeding, or something like
No. The question was, what was the importance of a history of Caesar and
yeah.
tetany,
So
and you have
that is
it out that suggests towards possible calciopenic rickets.
calcipenic
Fully
rickets. Yes.
So you said a positive family history is suggestive of congenital disease or inherited disease, right?
Yes.
That's what I said.
Yes.
So can a positive family history be there in absence of or in cases with acquired form of rickets?
Acquired form, yes, sir. If
So what would be the likely etiology in that cases?
sir, in those cases, even the nutritional cause will be there if there is any
Exactly. So
Yeah.
vitamin deficiency is pretty common.
Yes.
But is the commonest cause of calciopenic rickets, and the malnutrition in such children runs in family, right?
Yes.
So a positive family history does not necessarily point out towards an underlying congenital form of ricket.
Yes.
Okay.
Yes.
So can we have other participants to, what is the importance of this dentition history in rickets? He said delayed appearance of teeth, right? Understood? If I'm not wrong.
Yes, sir. Yes, sir. Yes, sir.
Appearance of.
Absolutely.
So what is the importance of dentition history in rickets? Does it point towards any underlying etiology? Does it help?
Sir, if there is any history of dental abscess, it can point to hypophosphatemic rickets. That's one thing.
Do you get a history of dental abscess?
Dental swellings or eruption, premature
And
falling of teeth,
right, loss of teeth.
loss
That
of
is more important. Loss of teeth. And anything else?
Presence of vitamin D deficiency early in the early stages itself. That is, nutritional deficiency, maybe prolonged breastfeeding, as in this case.
it can be
So
delayed
any,
eruption of teeth in vitamin D deficiency.
what about caries? Does it point towards any underlying etiology? Caries teeth?
I don't think so, sir. Dental caries are very common.
Okay, great. So is it associated with any form of ricket? I do understand that dental caries is quite common.
Not unless it is leading to any dental abscess or anything, sir.
So dental caries is somewhat common in calciopenic rickets, right? You get pulse abscess, loss of teeth in phosphopenic rickets, but enamel hypoplasia, caries, these are quite common in calciopenic rickets. Have you heard the term amelogenesis imperfecta? Anyone? No one. Fine, Nustu, can you discuss amelogenesis imperfecta a bit?
Sir, amelogenesis imperfecta is a type of it's a maldevelopment of the enamel, and if a patient is having rickets associated with amelogenesis imperfecta, then there is a certain indication to the rickets due to a certain type like distal RTA, and more specifically related to the WDR72.
Some patients of DRTA may have amelogenesis imperfecta, which is an important pointer to the underlying disease, right? So Anustup, go to your last slide. Go to your last slide.
Yes, sir.
The one before the examination. Right.
So this is the last
So
slide,
there
sir.
was a history of, okay, fine. Stay there. There was a recent history of painless progressive diminish of vision of left eye. So what is the importance of this history? What might be the underlying cause? Dr. Silika?
Sir, it could be a development of cataract in these patients.
Right. Very good. What
that-
does it suggest in this particular
Uh,
background?
Sir, in this background, it could be due to background of maybe hypoparathyroidism. Usually low calcium phosphate product could lead to such kind of
So
presentation, sir.
what is the etiology of cataract? Is it hypopara, that is low PTH, or hypocalcemia, or the product? Which one is important?
The product is more important than hypocalcemia alone, and hypopara.
Probably not. Probably not. Probably long-standing hypocalcemia is more important. That's why you get cataract in hypopara. So you get a history of rickets. You get some features suggestive of calciopenic rickets, like tetany, like seizure, and you get a possible cataract. So all these points towards underlying calciopenic rickets, right?
Right.
Okay, fine. So what is the importance of this polyuria, polydipsia, renal stone, and fracture in ricket?
Sir, this could be due to underlying renal tubular acidosis as an etiology of
Great.
rickets. So
Right.
we need to rule that out as well.
Right. So what is the cause of polyuria and polydipsia in renal tubular acidosis?
Presence of hypokalemia, hypercalciuria can cause nephrogenic DI.
Right. So hypokalemia giving rise to an acquired form of nephrogenic diabetes insipidus. Right. And some patients may have renal sodium loss also, which can also give rise to polyuria, dehydration, polydipsia. Right. Great. So, and renal stone, does it point towards any particular form of renal tubular acidosis?
So distal tubular is more commonly affected
Distal
in
arteries.
presence of renal stone.
Right. So is there any forms of proximal renal tubular acidosis in which you may come across renal stones? What you said is absolutely correct. This is more common in distal renal tubular acidosis. But can you get renal stones, nephrocalcinosis in proximal renal tubular acidosis?
Dent's disease.
Great, very good.
Dent's disease.
Anything else?
Topiramate can cause
Fanconi syndrome, sir.
No, Fanconi is, Dent's is right. Cystinosis, that is not uncommon. Cystinosis patients can also have renal stones, right? And Fanconi-Bickel syndrome, they may also have renal stone. So, and some patients of tyrosinemia may also have renal stones. So, okay, Anustup, go through your.
Yes, sir. Okay, sir. Thank you, sir. So, progressing towards the examination. So, these are the images of the patient when he presented to us. And so, we can see all the forms of all the rachitic changes are present. So, here also we can see we are finding the rachitic changes in these clinical pictures of this patient. And here we can see that in the eye, as sir has discussed regarding the presence of the cataract and also the non-development of the teeth, the dentition that has been discussed. Now the height, it could not be assessed due to severe deformity. The weight was around 15 kg. The Trousseau and Vostek signs were negative. And in SMR, the bilateral testicular volume was 2 ml, normal consistency, P1.
And he was 17 years of age, right?
Yes, 15 years of age at that time, sir. Currently he's 15 years of age. And per abdomen, there was no organomegaly, other systems, no abnormality was detected.
So stop there. So anyway, what are the possibilities? Dr. Sam?
Sir, calcipenic.
Calcipenic rickets
Yes.
due to?
Since it is presenting at this stage with the dental defects, so it can be VDDR, vitamin D, VDDR 1B, or
The symptoms started since 4 years of age.
Yes, sir. Yes, sir.
As happens quite common in our part of the world, the presentation was late.
Yes.
But the onset of the disease can be traced back from 4 years of age, right?
Yes.
Okay. So now give me your differentials.
So there can be either genetic defects of vitamin D metabolism, such as VDDR1B, which can present in early childhood or even at puberty, because of
VDDR1B.
1B. Yes, sir.
Okay, that is your first diagnosis. VDDR1B, it's not that common. What is
Yes.
VDDR1B?
Sir, it is 25 alpha hydroxylase defect.
So
Due
is
to
that the commoner form of rickets? Even if you
No.
think of inherited forms of calciopenic ricket, does it come as the first differential diagnosis in that list?
No, sir.
And is there any particular reason that you thought of 25 hydroxylase deficiency as the first differential?
Sir, because early onset in severe rickets, I was thinking on those lines because of that. But the more likely would be other causes such as 2B or others.
Right.
Because
So 1A, 2A, these are common.
Yes, sir.
These are somewhat more, these are all rare diseases, but
Yes.
relatively common compared to 1B, right?
Yes, sir. Yes.
Okay. So is there any possibility of conditions which may mimic rickets, but not actually is classified as rickets? Or in other words, have you heard the term of rickets mimickers?
Yes.
So what are the possible rickets mimickers?
Yes. So they can be either sir.
Yes, carry on. You are muted. Dr. Sam, you are muted.
Yes, sir. Yes. Sir, any nutritional deficiencies, severe protein energy malnutrition, any cases of
Do you get rachitic features or features which may resemble rickets in severe protein energy malnutrition? They might be having vitamin D deficiency rickets. So my question is, have you heard of any conditions which may mimic the skeletal features of rickets, at least on clinical examination?
So scurvy can be one.
Okay.
Hyperparathyroidism.
Hyperpara.
Okay, that has been reported. Yes, rickets has been reported in hyper.
Chondrodysplasias.
Right. So that is perhaps more common. Chondrodysplasias, particularly.
There's one condition.
Metaphyseal chondrodysplasia.
Right. Epiphyseal or metaphyseal chondrodysplasias. Number one. Number two.
Sir, it could be pseudo-hypoparathyroidism as well.
Yes, but more commoner than that.
Hyperphosphatasia syndromes.
What about mucopolysaccharidosis?
Mucopolysaccharidosis is also in the list,
That is
sir.
quite common and often misdiagnosed as rickets.
Right, sir.
Right. So is there any possibility of mucopolysaccharidosis in this patient? What are the points against?
Sir, mucopolysaccharidosis usually presents with coarse facies or hepatosplenomegaly.
Right. So coarse facies, mental retardation, organomegaly.
Failure to
come
thrive.
across corneal opacity, but not typical cataract, right?
Right, sir.
More importantly, you don't expect the calciopenic features in mucopolysaccharidosis unless it is associated with underlying vitamin D deficiency, which is not uncommon in clinical practice.
Right.
Right. Okay, so as of now, probably we are dealing with calciopenic rickets, and as rightly pointed out by Dr. Saumin, probably inherited form of rickets, inherited form of calciopenic rickets, possibly 1A, maybe 1B, I don't know as of now, or 2A or 2B, whatever. So can we rule out phosphopenic rickets completely? Anyone? Dr. Sania?
So there are no particular specific features of phosphopenic rickets.
What specific features do you expect in phosphopenic rickets?
Dental abscess or he's 15 years, so enthesopathy, so it won't develop so quick. But
And possibly they don't give a history of enthesopathy, right?
yes.
What is important? What is important?
And it will
They
be
don't
lower
have,
down
they
predominant
don't have calciopenic features,
calcipenic features.
right? So typically a phosphopenic rickets, patients of phosphopenic rickets does not have calciopenic features. This patient had tetany, had some cataract. So these are all features of calciopenic deficiency you don't expect in phosphopenic rickets, right?
Yes, sir.
Okay, so Nustup,
Yes,
take
sir.
us through your presentation.
Yes, sir. So in the workup, so we'll be dividing it into two. So the patients had some previous workups before coming to our institution. So this is a summary of the previous workups. So if you closely look into it, it is also given in according to the age at which the various parameters were done. So if we see the ionized calcium, it was done once when he was around 1.5 years of age. So it was 0.64 millimole per liter. One total calcium was once done, that was around 6.5 years of age. It was 5.23, as we can see. Now the phosphate was, although phosphate should always be seen in the background of age specific ranges, it was more or less around 4.5, 4.2 in that range, all the times that have been done. Now, regarding alkaline phosphatase, it has been done thrice previously. In all these cases, we can see elevated values are there. PTH was done once around 6.5 years. It was 148. Now, 25 hydroxy D was not available at any workup or any documentation before, and another report of 125 dihydroxy D was available. It was around 136.4. The lab at which it was done, it had given a reference range from 19.6 to 54.3. Creatinine was done twice, and it was around from 0.34 and 0.54. So it was more or less normal.
So yeah, carry on.
So
So
these are the imaging.
You stop here. You stop here, right? So yeah, discuss the imaging findings.
So the imaging findings are the rachitic changes are there. It was done before the cupping fraying. Those are all there since.
Or you can stop. May I ask someone to describe the changes in the radiology? Anyone from the participants?
So the physis growth plate is enlarged with metaphysis. Metaphysis appears to be splaying is there, fraying is there, and the number of carpal bones are only 4, sir.
Okay.
And this diffuse osteopenia,
Right.
very thin cortices,
So what does it suggest?
suggestive more in calcipenic.
Because of what is the etiology of these thin cortices?
The secondary
Right.
hyperparathyroidism, sir.
Right. So which we don't expect in phosphopenic rickets, right? So these
Yes,
are typical features of rickets with features of secondary hyperpara or telltale signs of calciopenic rickets. There is no doubt about that. And you get a delayed bone age. So that is somewhat expected. Anustup, you go back to your previous slide.
Yes, sir.
So now what is unexpected in this slide? Dr. Nupur?
Sir, the 125 OHD level.
Why? Why did you say so? Because one of the differentials was VDDR type 2.
Yes,
So
sir.
in that we don't we expect a high calcitriol level?
Yes, sir, we do expect.
So that is somewhat consistent with our working diagnosis, right? But
Sir,
what is
in this,
strikingly abnormal?
sir, phosphate should be low if you are expecting
Right.
this
So,
picture, VDDR2. So a normal phosphate in the background of raised PTH and raised 125 is a slight unexpected finding, sir.
so if you come across a normal or elevated phosphate in a patient of ricket, what would be your next investigation?
FGF23.
Do you expect normal phosphate in FGF23 mediated rickets?
It will be low, sir.
So, look, if you think pathophysiologically, all phosphates are phosphopenic rickets. All rickets are phosphopenic rickets. The classification is based on the primary etiology, whether the problem is defect in the inciting event is defect in calcium absorption, or the inciting event is renal loss of phosphate. In calciopenic ricket, the inciting event is decreased intestinal absorption of calcium because of low functional calcitriol. There is secondary hyperpara and there is renal loss of phosphate. So in all forms of ricket, except 2 or 3, you get low phosphates. So truly speaking, all rickets are phosphopenic rickets, right? So if you come across normal phosphate or high phosphate, what would be your next investigation?
We'll look for TMP GFR in
TMP-GFR.
such
No.
cases.
What would be your next investigation?
Urinary amino acids.
No. What would be your next investigation? It's serum creatinine.
Yes.
You need to rule out chronic kidney disease.
CKD.
Whenever you come across normal phosphate or high phosphate in rickets, always think of underlying CKD, right?
Yes.
So creatinine is normal. So why the phosphate is normal? Okay, tell me some conditions in which you get normal phosphate in rickets. In calciopenic rickets, you get low phosphate because of secondary hyperpara. In phosphopenic rickets, the inciting event is renal phosphate loss, be it FGF23 dependent, be it FGF23 independent. So name some conditions in which you may come across normal phosphate, but the child is having rickets.
Hypophosphatasia, sir.
Very good. Which form? More commonly in infantile form or in the childhood form, right? Anything else?
Increased bone turnover states, sir, could lead to normal phosphate.
Secondary to what?
Secondary to fibrous dysplasias or recent fractures.
In fibrous dysplasia, you get FGF23 mediated hypophosphatemia. What about distal renal tubular acidosis?
Yes.
Phosphate will be spared, sir.
Not necessarily it will be spared in all the cases, but majority of them have normal phosphate. So phosphate normal, rule out number 1 CKD, number 2 rule out DRTA because these are the commonest form, and then you rule out hypophosphatasia, right? Okay, so name 2 important investigations in all forms of ricket. 2 important investigations.
So first is ALP, the screening.
Great. And 2 is phosphate.
Phosphate.
So these are the 2 most important investigations in all forms of ricket. So now we discussed chronic kidney disease, but if we calculate the eGFR by bedside swatch, what would be the likely eGFR, Anustup?
Sir, it is coming normal, sir. in this
There
patient.
is nothing called normal. GFR
Okay, sir. Sir, sir,
G1,
yes, sir.
G2, G3, whatever.
Okay.
So
Sir,
at least
sir,
it's
around
not
90 to 95, yes, sir.
okay, fine. It's around G1 or G2, right?
G2, yes, sir.
So that has been ruled out. We discussed hypophosphatasia. Is it a possibility here?
No, sir.
Why?
ALP is very
ALP
high, sir.
is
Right.
raised.
So those two are ruled out. Number 3, possible DRTA, but the history was not suggestive of DRTA. And any other possibilities? Okay. Anustup, go through your presentation.
Yes, sir. So this was the imaging that was discussed. This was done at 9 years, 10 months of age. So this was also done at the same time, the imaging.
So what do you show here? Do we call it a triradiate pelvis?
Yes, sir.
Okay.
So moving on, after the patient was admitted, so this is the preliminary post-admission workup. So here
this
we can,
when you first saw the patient, right?
yes, sir.
Okay.
When we first saw the patient in our institution and following admission, this was the initial investigations.
So once again, the findings are not much different, or this is consistent with your previous investigations.
Yes, sir.
Only thing, you did not have any documented normal 25 hydroxy vitamin D in the medical
Yes, sir.
records. Now you
Yes,
have
sir.
documented a normal 25 hydroxy vitamin D.
Yes, sir.
Somewhat high PTH. Once again, alkaline phosphate is high, creatinine good, but once again, phosphate is normal, right?
Yes, sir.
Okay. So anyone? Any comment on that? Dr. Shomin?
Sir, so that is the one discrepancy that is there. If there is,
That is
Right.
striking, right?
yes.
Okay.
In case of otherwise, it should have been less. Then it would fit completely. The vitamin D deficiency.
So once again, we do not expect calciopenic features in distal renal tubular acidosis, right?
Yes.
Why? Simply because the serum calcium most of the time remains normal. And what happens in acidosis? What happens to ionized calcium?
It increases.
It increases.
Right. So that's why even in CKD, despite significant hypocalcemia, we don't often come across tetany, right?
Yes.
Okay. So take us through, Anustup.
Yes, sir. So this was the ABG baseline that was done on admission. So
Right.
nothing.
So once again, you have ruled out renal tubular acidosis.
Yes, sir. So
Okay.
this was the radiology which was done at admission.
Nothing new, right?
Nothing new, sir.
Significant features of secondary hyperpara.
Yes, sir. Thinned out cortices.
And what is important is there is no healing line. So
Yes,
despite
sir.
having severe repeated dose of vitamin D, the child is not showing any healing lines.
Yes, sir.
Right. What is resistant ricket, by the way, Dr. Nupur?
The absence of the provisional zone of calcification following 6 weeks of adequate treatment with vitamin D and calcium.
Okay, great.
So
okay, yeah, carry on.
yes, sir. So this is the summary that we have discussed till now. So it's 15 years, 10 months male presenting to us with clinical features and radiology suggestive of calciopenic rickets, as has been mentioned. The onset of disease is 1.5 years of age. From biochemical point of view, we have found low calcium, normal phosphate all the time, high alkaline phosphatase, high PTH, normal creatinine or renal function, normal 25 hydroxy vitamin D, which is documented recently, and high calcitriol values. And
So everything is fitting with VDDR2. Only the phosphate cannot be explained as of now, right?
Yes, sir.
Okay. So any
And there
comments
is
from the participants? Do you agree with my diagnosis? VDDR type 2?
Yes, sir, that could be
Yes,
the
sir.
working diagnosis as of the available information.
Oh, great. So carry on, Anushka.
yes, sir. So now at this point of time, we are thinking about the possibilities, as Sarah has mentioned. So we are
So what
thinking.
about isolated calcium deficiency ricket? What do you expect in the biochemistry, the hormonal profile in isolated calcium deficiency ricket? Dr. Sustri. Okay, anyone?
It's seen in children who are exclusively breastfed, sir,
Right.
infants. And because breast milk is a very poor source of vitamin D, the mechanism, I mean, vitamin D deficiency is the mechanism. So phosphorus should be
No,
low.
I'm not talking about vitamin D deficiency ricket. I'm talking about isolated calcium deficiency rickets. There are hundreds of cases from Zambia about isolated calcium deficiency rickets. So my question is, what do you expect in the biochemistry in isolated calcium deficiency ricket? What disease does it mimic? It mimics VDDR type 2.
Okay.
Vitamin D is normal, low calcium, high PTH, low phosphate. Because of low phosphate and high PTH, there is high calcitriol. So whenever you come across high calcitriol, your diagnosis would be VDDR type 2. May not be 2A, it's type 2. Depending on alopecia present or not, you decide on whether it's 2A or 2B. And you don't forget the underlying possibility of isolated calcium deficiency rickets. Though it's rare, but it happens, right? But once again, you don't expect phosphate level to be normal in isolated calcium deficiency rickets. Okay, next one.
Yes. Question that has been there for the last few minutes is that why phosphate has been normal all throughout, and also why PTH
It's not so high.
Okay, so we have discussed.
Yes, because we have found out.
Yeah. So give me your explanation, or rather, I'll give us your explanation.
Sir, is there a possibility of
So
hypopara, sir?
Just a second. Go back. Yeah, carry on.
Hypopara possibility, anything, sir? Because
Hypopara.
yes, sir. I
Which
mean,
form of
PTH.
hypopara? So do you expect a PTH in the range of 80s and once it was in the range of 100 in hypopara?
It's inappropriate to the level of calcium, no, sir.
So how do you, if I say this is pseudo hypopara, it's not hypopara. Do you have any cutoffs for PTH to differentiate hypopara from pseudo hypopara?
I'm not aware, sir.
Anyone? Low calcium, high normal phosphate, and the PTH say less than 1. Your clear-cut diagnosis is hypopara.
Yes,
It's
sir.
10, it's 20, it's 30, it's 80. What's your diagnosis? The calcium phosphate being same. Low calcium, high normal phosphate. When do you say this is inappropriately normal? So what's your appropriate level for that?
20, sir.
Very good. So I don't know the level of the strength of evidence, but it has been suggested that you take I would say it's an arbitrary cutoff of 20. Beyond 20, probably you are dealing with pseudo hypopara, but once again, I emphasize that the level of evidence is not very high. So what about a possible pseudo hypopara? So you brought hypopara. I am saying this is not hypopara, this is pseudo hypopara.
So the possibility that the patient had cataracts also points towards maybe it is some hypopara-like condition, like we said, that it is due to low calcium as well as relatively low PTH.
Right. So do you expect the alkaline phosphatase level to be in thousands in pseudo hypopara?
That's again contrasting.
Do you get the typical rachitic features in pseudo hypopara?
Not so common, sir.
Why? The calcium level is normal, low. So then why don't you get the typical rachitic features? What is the important biochemistry underlying these rachitic features?
Sir, since the phosphorus is
Low
deficient,
phosphorus.
Exactly.
chondrocyte
The low
apoptosis does not
phosphorus,
take place.
right, absolutely right. That's why you don't expect the typical radiological features. So what's happening? It's pseudo hypopara with some form of ricket. What's your opinion? Okay, Anustup,
Yes,
give
sir.
give us your explanation.
So, sir, for this, we have to just go through the molecular action of the PTH. Now, here it is depicted, it has been taken. So, the PTH receptor, so from that, upon stimulation by PTH and or PTH-RP, so it has got two paths to go. So, one is the GS alpha, and the other is the GQ. So if we go by those two, so in the GS alpha, as we know the GS alpha signaling, ATP to cyclic AMP, activation of protein kinase A is the GS alpha mediated, and the GQ mediated, as we know, is by the IP3 DAG pathway, where it stimulates the protein kinase C pathway. Now the difference between these two is an important finding. The important difference is that the intracellular calcium levels are the intracellular calcium is required in the IP3 DAG pathway via the GQ. So this is a fundamental difference between these two. Now if we go to the PTH signaling in bone, so in bone the PTH primarily utilizes the protein kinase A pathway in exerting both its catabolic and anabolic effects. And the PKC protein kinase C pathway via the GQ has got limited role in PTH signaling. But if we go to the parathyroid signaling in kidney in the PTH receptor, so it predominantly acts through the protein kinase C pathway in the proximal convoluted tubule for the sustained phosphaturic action. So this molecule, that sodium hydrogen regulatory factor 1, it forms a complex with NAPI2A, the sodium phosphate transporter in the proximal convoluted tubule, and it stabilizes its expression. But PTH through the protein kinase C pathway destabilizes this complex and causes internalization of the NAPI2A, as a result of which we get a phosphaturic action of PTH upon acting through PTH receptor and the protein kinase C pathway. So in our patient, what we see is the explanation to this phosphate level is that due to severe persistent hypocalcemia since childhood, so there is not only extracellular calcium deficiency as is depicted in the blood parameters, but there is also intracellular calcium deficiency. Now, these intracellular calcium levels are very important for the protein kinase C pathway, as you have depicted, which is functional in the proximal convoluted tubule. And so, as a result of that, so there is resistance to the protein kinase C pathway of PTH action, and the phosphaturic action of PTH gets impaired. And so, we get an inappropriately normal phosphate level as was expected. And so we call, as sir has been telling, sir, you have been telling that it is the type of pseudohypoparathyroidism. It's an acquired form of pseudohypoparathyroidism type 2, which we usually see in cases of severe calcium deficiency.
So you must have read that the two common etiologies of type 2 PHP, the acquired etiologies, are myotonic dystrophy and vitamin D deficiency. The message is clear. Vitamin D deficiency is most commonly associated with hypophosphatemia simply because the serum calcium level is often low normal or slightly low. But if vitamin D deficiency is associated with severe hypocalcemia, then and only then you come across the pseudo hypopara type 2. So meaning thereby severe hypocalcemia of any etiology, be it vitamin D deficiency, be it anything, can give rise to an acquired form of pseudo hypopara, and you may not come across low phosphate in calciopenic rickets, irrespective of etiology, where calcium level is pretty low. So that is the message.
Yes, sir.
So I think we have taken 55 minutes. So rush through your presentation, rest of the presentation, because they have a quiz too.
Yes, sir, surely. So we started the after the investigations, which treatment was, we started with IV calcium infusion, and we started with oral calcitriol 0.5 microgram BD. Now, the treatment response, if we see this graph, and if we see this flow chart, if we see this page, that the calcium level on with treatment, it increased from day 0 to day 10. Now, we also saw that the phosphate, which was 4 milligram per DL on before, it became less and became 1.93 on day 10. And the TRP, which was initially I mentioned 93.4%, we measured that as well. In the background of the developing hypophosphatemia, we got a TRP of 99.96. The simultaneously, the TMP GFR, which is to 3.73 to begin with, it became 1.92. So there was a discrepancy between the TRP TMP GFR as well. And the urine protein by urine creatinine ratio in the background of hypophosphatemia on treatment, post-treatment day 10 was low, 0.003. And the PTH, which was 87.2 to begin with, on the day of 10 day of treatment was 42.2.
So
should
carry
I
on.
proceed?
Yeah. Finish it off.
Okay. So this was the patient improved after 1 month. So our provisional diagnosis, as has been discussed, calciopenic rickets, likely VDDR2A. But once again, the questions arise: why the TMP GFR was low on the day 10 of treatment, and why PTH became normal.
So once again, once the calcium got normalized, there was phosphaturia. We expect phosphaturia and the phosphate becomes low. But surprisingly, the TMP-GFR should be high in. It was low, right?
Yes, sir. Yes, it was low.
So that suggests renal loss of phosphate, right?
Yes.
So because of now normal PTH action.
Yes, sir.
Okay,
So,
great.
so now, so we discharged the patient because of low for the phosphate level. We predicted a diagnosis that
This
with
was the
treatment.
genetics. Use was the genetics.
No, this was before the genetics. So
no, use
so
was the genetics, right?
Yes, but much surprisingly, the genetics, it came out to be in favor of VDDR1A.
So you stop here. So just to summarize, the purpose of presenting these cases was two. Number one, as I have already discussed, you don't expect phosphate to be low in all forms of calciopenic rickets, particularly in cases of severe calcium deficiency because of that PKC pathway defect. And number two, calcitriol assay is not standardized. So don't rely much on serum calcitriol level to reach a diagnosis, because it circulates in picogram per ml in concentration. So there are assay variability, there is inaccuracy, there is lack of standardization with calcitriol assay. More importantly, you have to know the age specific reference ranges of calcitriol. So don't rely much on calcitriol to reach a diagnosis, which perhaps more important in certain forms of FGF23 independent hypophosphatemia rickets. So I think we should stop here. Over to you, Dr. Sandeep, for the quiz.
Okay, sir. Thank you, sir.
Sir, once again, very thankful for this, and it was very lucid and true masterclass on rickets. And you very beautifully, taught to the students how, from the simplistic clinical approach to one of the difficult unlocking of the difficult algorithms in rickets evaluation. Thank you once again, and thank you, Dr. Mukherjee, for very, very good presentation. And with this, I would request Dr. Anushtup to please, if you can unshare your screen, and I would share my screen for the quiz presentation. So dear students, I hope you're ready, and we just have a fast revision. The quiz would be very simple. So I think my screen is visible to you. Okay, so all of you have been attending these quiz, and we do it on www.menti.com, and all of you are aware, but just for a revision, I would just discuss the rules and instructions for this quiz. Okay, so basically, you require two smart screen devices. So one screen is one on which you are watching me right now, and another smart screen device is required to attempting the quiz. Like you can have your smart screen, your smartphone for doing that. So how you can enter or access this quiz is simply go to www.menti.com and enter the code which is displayed there, which end by 100, or you can use the scanner, scan this QR code, and that would give you access to this quiz. So during the process of the quiz, if you happen to log out from the quiz, you can again re-enter. Don't worry, don't panic, and there would be this code would be displayed in all the subsequent slides. And just a revision of the rules. We've been doing it for a very long time. And so we've discussed we need to have two smart screen devices, and we are not looking for the correct answers only. So we are looking for the fastest correct answer. So this menti.com, automatically has a software which will select the person who has answered the fastest. So kindly obey and respect and notice the time as well. And not to mention, decision of the quiz master would be final. And I see a lot of people are raising their thumb and they have joined, and we wait for a few seconds before we begin with the first question of this quiz. It will be very simple, and we have already short of time, so we'll rush through and to this quiz, and we will be having very less number of questions compared to the earlier quizzes. So wish you all the best. We're looking for the fastest correct answer. So please respect the time. And even if you have all the correct answers, still you may lose. You may not win. So please, the time is very, very important. So fastest correct or right answer is must. And the QR code is displayed on the top of the every slide. Like in the present slide also, you can see the QR code 1100 is displayed, and which can be utilized for accessing this quiz from your smart screen device like a phone. So I hope all of you are now have accessed the quiz. So we are now good to go, and we proceed now. So basically, okay, so we are good to go now. So most of the participants have joined, and many of them are joining. So with this, I enter the first question of the today's quiz. So the first question comes very shortly on your screen. And the question is, among the renal tubular acidosis, the rickets is more common in what? This was discussed by the faculty very, very exhaustively. In which of these form of the rickets, the renal tube, the RTA, the rickets is more common. May happen in the other forms also, but in this form, it is a little more common. So the correct answer was this is a type 2 RTA, proximal RTA, that rickets is more common in them. And yes, we have a leaderboard here. So these are very preliminary. Don't worry. This was kind of a warm-up question, but it would be included for a scorecard. And yes, we have a close competition on many of them, but still don't worry. People who are lagging, you have a lot of options to catch up. And this comes directly from your Williams. Most of your question, in fact, the majority of a question would be directly from your Williams. And type 2 RTA or proximal RTA generally have more common. Rickets and osteomalacia is more common in these form of renal tubular acidosis, and this happens because phosphate is generally seen to be lower in this, and Fanconi kind of syndrome is seen in the proximal RTA. So I think with this, now the people have warmed up, and don't worry, people who could not answer this correctly. So you have a lot of options, but please remember that we are looking for the correct answer in the fastest possible time. So it's the fastest finger which we respect here. And the question number 2 comes on a quiz, the screen here. And the question goes as the vitamin D content of human breast milk. Again, it was discussed. Most of the question would be discussed by the faculty moderator. So it is 25 IU per liter, 250 IU per liter, or 2500 IU per liter. So now we have finished with the time, and the correct answer was 25 IU per liter. And I'm little disheartened that it was a very simple one. So basically, just one thing you should remember, that breast milk is a very poor source of vitamin D. In fact, there can be a development of the rickets. That is why only the women, the pregnant lady, has to be at times supplemented with the supraphysiological doses of the vitamin D. And again, this question is from Williams. And with this, we go to the question number 3. So thinning of the cortices in the long bones is the earliest radiological manifestation and seen in all forms of the rickets. This statement is true or false? So again, a simple one, and we never, despite this is a two isolated things, the case presentation and quiz, but since there's a common, the common questions which come, so this was discussed during the case presentation by the respected faculty. And the answer to this is false statement, because thinning of the cortices of the long bone, yes, it is the earliest manifestation of the rickets, but it is not seen in all forms of the rickets. And answer was discussed that X-linked hypophosphatic rickets does not have thinning of the cortices, where you can have a thickening of the cortices which can be seen. And again, this question was from your Williams. So 15th edition. So again, it emphasizes that how important is a Williams. So please focus on this X-ray image. So the next question would be based from this X-ray image. So I have highlighted this certain things on this X-ray image with these arrows. And this again is a very simple one. Most of you would be able to answer this. So next question would be based on the things which are highlighted on this chest X-ray. And the question comes here on your screen. And the question goes by this. So question is, this patient present with hypercalcemia and negative MON2s. Identify the conditions. So it is sarcoidosis, tuberculosis, or MEN1 syndrome. So which one is the correct when you connect the hypercalcemia and negative MON2 test, please X-ray finding. Again, a simple one, and I expect 100% of you should answer this correctly. So yeah, yes. So most of you could answer it correctly, but still some of you missed it. So this was a sarcoidosis, and chest X-ray revealed. So what is a sign? So this is called as a 1, 2, 3 sign or Garland sign. So that is which we see in the chest X-ray, and what we see is and we have a MON2 which is said to be anergic. So MON2 in the sarcoidosis is anergic, means we don't see any response. And hypercalcemia, most of you would be aware, because it's a granuloma which present with 1-alpha hydroxylase activity, and we can see higher hypercalcemia in sarcoidosis and as well as in other diseases. So we can have a quick check at the leaderboard here, and again we have a very tough competition, close competition, and probably most of you are able to answer it correctly. Just because of time the factor, probably you are lagging, and we have a close competition between Dr. Shilika, who's leading, Dr. Somya, the magical Rhino, Amulya, Sachin. All the best. All of you have a close fight, and there's a lot of opportunities to catch up, and the time would be critical for that. So the next question is here on your screen, and the question goes as this. So negative allosteric modulator of CSR is. So the options are cinacalcet, inacalrate. Which one is the negative allosteric modulator of CSR? So this is a little recent advance, which So the correct answer for that is inacalrate. So negative allosteric modulator is CSR, which is an investigational drug in advanced phases of the research. It has been seen that it negatively modulates CSR and has been utilized for treatment of the autosomal dominant hypocalcemia. And whereas the cinacalcet, which most of you would have used in your practice, is a positive modulator which causes a decrease in the PTH. So this is very important to remember, that the cinacalcet is a positive modulator of CSR. The negative is cinacalcet, and this is a recent advance, and I remember this was discussed in one of the NBE classes which are conducted for you by the national board. So next question is here on your screens. So iron infusion related rickets. So rickets can happen with the infusion of iron like ferrous carboxymaltose. So what kind of rickets is this? This is a acquired FGF23 dependent or hereditary FGF23 dependent or FGF23 independent rickets. So which one is the correct options here? Okay, so most of you, I'm happy that many of you could answer it correctly. This is acquired FGF23 dependent rickets, and you should remember that iron infusion like ferrex carboxy maltose causes, elevation of FGF23, and this is a form of acquired FGF23 dependent rickets and not a hereditary FGF23 dependent rickets. And you should also remember there are certain drugs like tenofovir in HIV patient, etc., and many other drugs like anti-epileptics which can lead to the rickets. So when you're taking the history, this again becomes very, very important. So it will be a good idea to take a research in one of your institutes where hematology department probably would be giving a infusion of the iron and how much FGF23 elevation and occurrence of the rickets happen in them. So we are almost 75% through with the today's quiz. So it's time to catch up really hard. And the question of number 9 is here on your screens. And the question is, so mechanism of action of brosumab is a recombinant IgG1 monoclonal antibody against what? It is against VDR, FGF23, rank ligand, or sclerostin. I think it's again a simple one, and you remember brosumab is a drug which is been approved by FDA, Japanese authority, and even the European agency for the okay, so for the management of the X-linked hypophosphatemic rickets, and the correct answer it is a monoclonal human recombinant IgG1 monoclonal antibody against FGF23, and this is very important to understand. I'm disheartened that many of you could not answer it correctly. And sclerostin is a ramosujumab, which you should remember, which is a drug, osteoanabolic drug for the osteoporosis, which is available now in the India, and we can have a quick check in the leaderboard again, and we now have a little, the little change which has happened, and but there's a close competition between Dr. Somya, Pratmesh, Banu, Raveen, Anuj Bhan, Dr. Amulya, Isha. So all the best to you. Please catch up, and you can, because the point competition is very close. And we now proceed to the next question, and the question number 9 is here on your screens. So enthesopathy, very simple one. Enthesopathy is a feature of which rickets? So it is X-linked hypophosphatic rickets, vitamin D deficiency rickets, or vitamin D dependency type 1V rickets. So it's a feature of which out of these? So again, it's simple one. I expect many of you will answer it correctly. So your time is over now. And the correct answer is, I'm sorry, still people made it wrong. And the correct answer is X-linked hypophosphatemic rickets. Please remember, there are few features which differentiate, X-linked hypophosphatemic rickets from other one. And the enthesopathy is one of them. And sir also told you about the tooth loss and tooth abscesses, pulp abscesses, which can happen in the dental finding. And on the contrary, in the calcium, the vitamin D deficient, you see the enamel hypoplasia and the caries which are common. So these are the few distinguishing features, and the one which I told you on the X-ray, there would be a thickening of the cortices which can be seen in X-linked hypophosphatemia rickets. These subtle features are very, very important to be picked up, and this may build on your evidence to the probable diagnosis, which you can further reinforce with the relevant investigations. So leaderboard, again, we have we have same pattern but close competition. So we have a people who are within 100 points, so time factor would be important, and still the people can catch up. And we come to the second last question of today's quiz, and the question is here on screen. So vitamin D fortification of the milk is mandatory in India. So is this statement true or false? That am I asking here. So this statement is false, and I'm sorry, many of you could not answer. So the vitamin D fortification is not mandatory in the India, and you should be aware that which are the foods which can be fortified with the vitamin D. We can fortify the oil, we can fortify the milk, but it should be remembered when we remove the cream. part of this, that these nutrients are are removed. So that is one of the shortcomings. But yes, so it is not mandatory, but fortification happens in India, but it is not mandatory as per the government laws. So the last question for today's quiz is here on your screen, and the question is, so skeletal abnormalities or signs seen in the cranium in the rickets are all except. So I'm not just talking about the cranium. So craniotabes, so all are seen except bullet deformity or tailor-wise abnormality. So which one is not seen in the cranium in the patient of the rickets? So everyone has voted, and the correct answer is, so correct answer is tailor-wise abnormality, and you should be aware craniotabes and bullet deformity are the features of the cranium in the rickets. And what is the bullet deformity of the bullet deformity is a pointing of the occiput part, which is a classical feature seen in the cranium. Craniotabes is obvious, and tailor-wise abnormality is seen in the spine, which is called as tailor-wise posture in the patient with the rickets. So with this, we have finished all the questions for today's quiz. I think this was educative, and despite many of you could not be in the top 3, but still the aim was not to select the top winners, but some kind of ignition should go, so that we go with some kind of learning. And obviously we learned a lot from today's case, which was very lucidly was discussed by the respected faculty. But yes, we have to declare the top 3 winners, and the quiz leaderboard has settled. Dr. Prathamesh, congratulations to you. You have won with 9225 points, and you win the 10,000 cash prize. Dr. Anuj Bhan is the second. Dr. Raveen Thomas is the third, and you win 7,500 and 5,000 rupees respectively. Kindly contact me for claiming your cash prizes. And thank you once again. Thank you, respected faculty. Thank you, panelists and presenter, and all the audience. And we meet you again on the last Wednesday of June, where we would be having another interesting case for the case capsules. And we are committed to make this very, very academically interesting and enhancing. Thanks a lot. With this, we close today's case capsule. Good night. Jai Hind.
Good night. Thank you.
Thank you, sir.
Thank you.
Thank you, sir.